today I'm going to read the Cardiovascular System examination exactly the way it is written in my practical book. And instead of just passively reading it alone, I thought let's read it together. I'll go line by line, explain what each step actually means clinically, and I'll tell you what examiners are really looking for in your medicine practical Viva. This is not just theory, this is how you present in the exam hall. So if you have your medicine practical examination coming up, open your book, sit with me, and let's understand it properly, not just memorize it. So let's start. So let's start with the cardiovascular system examination. Body mass index, you have to see an ischemic heart disease and atherosclerosis, decubitus. There can be orthopnea, which is sitting position, left ventricular failure, pericardial effusion, mitral stenosis. Platypnea can be seen in case of atrial myxoma, pulmonary AV shunts. Leaning forward will be seen in case of pericarditis. Squatting will be seen in tetralogy of Fallot. Temperature. Look for temperature in case of infective endocarditis. There will be fever. Change to respiration will be seen in severe heart failure. Blood pressure will be increased in hypertension, obviously, but it will be decreased in arrhythmias, AS, severe MS, and left ventricular failure. Wide pulse pressure is seen in aortic regurgitation. Look for edema, look for cyanosis. Cyanosis you'll see in cyanotic heart disease, obviously, because cyanotic heart disease. Pulmonary edema, left to right shunt, plus reversal. What is reversal? It is the Eisenmenger syndrome, Eisenmenger phenomenon. Clubbing. Oral cavity, unhygienic. If in case of infective endocarditis, the oral cavity will be unhygienic. Look for tobacco chewing, smoking, tobacco staining of hands. They'll be having ischemic heart disease. If there's any tattoo mark, there's risk of right-sided infective endocarditis, right-sided. Atherosclerotic stigmata. What is a atherosclerotic stigmata? So you have locomotor brachialis, xanthelasma, xanthomata. Xanthelasma and xanthomata are those yellowish plaque-like plaques that you will be seeing on top of your eyelids. Then you will be seeing cord-like arteries, peripheral vascular disease, like it can be embolic or thrombotic. Tobacco staining, arcus senilis. Arcus senilis is like it's basically a ring seen in old age, ring around in the eye. Peripheral signs of infective endocarditis, immunologic lesions like rot spots, Osler's nodes, seen in the pulp of fingers, which may be painful. Vascular lesions, Janeway lesions, palm and sole, painless. So Osler's nodes are painful, but Janeway lesions are painless. Then look for petechiae, purpura, splinter hemorrhages, splenomegaly, and PVD. Duke's criteria, we all know what that is. Peripheral signs of AR, check in your standard textbooks. First, now we are going to look at systemic examination. Systemic examination in any case should be started like this. The patient was examined with due consent under adequate illumination, well exposed till the umbilicus in sitting and supine positions in presence of a female attendant, only in case of female patients. Then the first thing you have to do is inspection, obviously. Look for the shape, look for symmetry, which will be affected obviously in kyphoscoliosis, straight back syndrome, pectus carinatum, pectus excavatum. Precordium, there can be a bulge or a depression. Pulsation, apex impulse. Other precordial impulse like left parasternal, in right ventricular hypertrophy, in the left parasternal lesion. Other pulsations you can see is epigastric pulsation seen in RVH, abdominal aorta aneurysm, pulsatile liver mass. Supraclavicular pulsations are seen in supraclavicular aneurysm, hyperkinetic state, coarctation of aorta. Suprasternal pulsations are seen They can be physiological, and they can be seen in hyperdynamic states. Aneurysm of aorta, coarctation of aorta, AR, pulsatile thyroid. Carotid pulsations are seen in Corrigan sign, that is, it is seen in AR. Carotid body tumor, hyperdynamic states, coarctation of aorta. Look at the skin, then look for scars, sinuses, any dilated veins. For the apex impulse, say the apex impulse is seen just below the left nipple in the mid-clavicular line. Definition of apex impulse: the lowermost and the outermost part of precordium where pulsation or systole is best felt. Normally, it is seen below the nipple. It is seen only in one ICS only, and has area of 2.5 centimeter diameter. So, what abnormalities of apex impulse are there? There can be diffuse apex, that is, it is seen in more than one ICS. What are the causes of diffuse apex? Hyperdynamic states, AR, volume overload. It is not seen in left ventricular hypertrophy due to pressure overload, because there's pressure overload in LVH. Increased or forceful apex. It is seen in LVH because, as we said, there's pressure overload. Then if there's a thin chest wall, apex impulse may be absent in MI due to weak pulsations. If there's a thick chest wall, if there's breast tissue, if there's pneumothorax, pleural effusion, emphysema, pericardial effusion. Displaced apex. Cardiac causes: LVH down and out, RVH out, dextrocardia. Extracardiac causes of mediastinal shift, push and pull effect, kyphoscoliosis, pectus excavatum or carinatum, straight back syndrome, ascites, pregnancy. Bifid apex is seen in HOCM. Retraction of apex, that is broad bends apex, is seen in adhesive pericarditis. Apex impulse is an inspectory finding, that is, you see it. But apex beat is a palpatory finding, that is, you feel it. So on palpation, you have to compulsorily say inspectory findings are confirmed on palpation. Say there's no local rise of temperature or tenderness on superficial palpation. Points to be covered: apex beat, other pulsations like parasternal heave, epigastric pulsations, then palpable heart sounds, thrill. What is thrill? Thrill is palpable murmur. Look for tracheal tug, carotid artery shudder. Apex beat. Say the apex beat is localized at this side and of this type. Definition of apex beat: the lowermost and the outermost part of precordium where pulsation systole is best felt, first palpated in the supine position. If not felt, ask the patient to bend forward or shift to the left lateral position. These enhance the palpation of apex beat but also shift it from the normal position. Correct method for localization: first palpate by palm, then by ulnar border of hand, and then by the tip of index finger. Normal location is at the 5th left intercostal space, 1 centimeter medial to the left midclavicular line. In tall patients at the 6th intercostal space, and in children at the 4th intercostal space. Now, there are types of apex beat. One second. Okay. Normal apex beat, it is brief with the gentle thrust. It is not forceful, palpable with certainty. Hypokinetic, minimal thrust is seen in thick chest wall, pleural effusion, thick pleura, chronic obstructive pulmonary disease, pericardial effusion, MI. Tapping is, it means the apex beat is ill-sustained, that is, and non-forceful. It is seen in MS. Only one cause. So if they ask you where is tapping beat seen, just say MS. Heaving apex beat, it is well sustained and localized to one intercostal space and forceful. It literally lifts the finger. It is seen in pressure overload conditions like LVH. Hyperdynamic. What is hyperdynamic? It is ill sustained, forceful, and diffuse. That is more than one intercostal space. It is seen in volume overload. Retractile impulse, also known as broad bend sign, it is seen in adhesive pericarditis. Double impulse is seen in HOCM. Parasternal heave. Methods, ulnar border of hand. This is the ulnar border of your hand. Pen method, oscillatory movement of pen kept parasternally. You have to keep the pen and look for oscillatory movements. Base of hand according to some authority. So this is the base of your hand. This causes RVH, most common aortic aneurysm, left atrial enlargement. Grading of parasternal heave. So grade 1 is palpable, you can feel it. Grade 2 is palpable and obliterable, that is, you can obliterate it and feel it. And grade 3 is that it is palpable, you can feel it, but you can't obliterate it how much ever you try. So epigastric pulsations, by the 3-finger method to differentiate the RV pulsations from abdominal aorta aneurysm. Index finger, pulsatile liver mass, middle finger, RVH, ring finger, abdominal aorta aneurysm. This is a 3-finger method, just like in surgery. Palpable heart sounds. S1 at the mitral area, MS. S2 palpable P2 diastolic shock at pulmonary area, pulmonary hypertension. S3 at mitral area, left ventricular failure. At tricuspid area, then right ventricular failure. S4 at mitral area, then left ventricular failure. Thrill, it is a palpable murmur of low frequency. So if someone asks you what is thrill, then you have to say it is a palpable murmur, but of low frequency. Say site and timing. Timing as in diastolic or systolic. Then same as murmurs. So on the fingertips, you will see, you will look for pulsations. On the base of fingers, you will look for thrill. On the base of hand, you will look for heave. Edge, hand, heave. On the palm, you will look for diastolic shock. On the ulnar border over here, you will look for heave. Brachial tuck, what is that? Oliver sign. It is seen in aortic arch aneurysm. Method, on upward traction of cricoid, we feel downward tug with systole. Carotid shudder, vibration felt at the height of carotid pulse. It is a pathognomic sign of AS plus AR. Percussion, say the heart borders are normal with no cardiomegaly. Base of heart, normal in the left third intercostal space. If second left intercostal space is dull, then pericardial effusion, atrial enlargement. Right border, normally retrosternal. Start percussing on the right mid-clavicular line. Right, okay, right. To find the liver dullness. Then one intercostal space above it, continue percussion leftward. If dullness in right parasternal area, it indicates right atrial enlargement, RVH, ascending aorta aneurysm, pericardial effusion. Left border, normally it is 1 centimeter medial to the mid clavicular line, that is at the apex. Start from the mid axillary line, then go rightward. Right, okay. If both apex and the left border are shifted to the left, it indicates LVH or RVH or mediastinal shift. If both apex and left border are shifted to the right, it indicates a mediastinal shift or dextrocardia. Makes sense. If only left border is shifted to the left but apex is at normal location, it indicates pericardial effusion. So what is Dorendorf sign? Supraclavicular fullness due to an aortic arch aneurysm. Oh, okay, I didn't know that. Potain sign, dullness at the right upper sternal border due to aortic arch aneurysm. Principles of percussion, flexor and this is something they ask all the time. They'll ask you in first year as well, as far as I remember. Flexor and fleximeter, the movement has to be done at your wrist joint. Direct percussion over the bone. So if there's a bone like clavicle, then you just directly percuss on it. Indirect percussion over soft tissues. Suppose you're percussing over the liver to look for liver dullness. Then indirect percussion is एक फिंगर के ऊपर दूसरा फिंगर ऐसे ऐसे ऐसे. That is indirect percussion. Compare identical areas. So if you're doing it on this side, then compare the corresponding area on the left side. If you're doing it on, you get it right, yeah. Cardinal rules of percussion. Pleximeter should be parallel to the border of organ and it should be moved perpendicular to the border of organ. Heavy percussion for deep organs and light percussion for light organs. Always progress from the high note, that is tympanic, to the low note, that is dull note. Now उसके बाद you'll do auscultation. Say only relevant and positive findings. Auscultate the following hard sounds. Okay, S1, S2, S3, S4. S1 ejection click, systolic murmur, others pericardial rub. Adventitious sound due to technical errors like rubbing of clothes, etc. S2 opening snap, diastolic, pericardial knock, and due to technical errors like rubbing of clothes, etc. S3 continuous murmur, prosthetic valve sound, and S4 tumor plop. Look at the diagram. Areas of auscultation on the chest. Okay. So we have the area of auscultation. Mitral, start from here. Left fifth intercostal space, 1 centimeter medial to the mid-clavicular line, the apex. This palpation is apex. This palpation is must before auscultation to note if apex is shifted. Tricuspid left fourth intercostal space, parasternal. Aortic right second intercostal space, parasternal. Pulmonary left second intercostal space, parasternal. Erb's new aortic area left third intercostal space, parasternal in patient of AR by leaning forward in expiration. Gibson's left first intercostal space, parasternal in patient of PDA. Heard best in right-sided auscultation, sounds murmur in inspiration. Left-sided auscultation, sounds murmur in expiration. Hard sounds, S1 is lub, it is longer, it is of low frequency and it is softer. S2 is dub, it is shorter, it is of high frequency and it is louder. How to identify S1? Correlate sounds with pulse on arteries. S1 to S2 gap is shorter than S2 to S1 gap. Nature of S1 and S2 are different. S1 is better heard at the mitral and tricuspid areas, while S2 is better heard at the aortic and pulmonary areas. Use of the bell, the part, you know what the bell is, right? Yeah. For low pitch sounds like mid diastolic murmur, S3 sound, S4 sound, fetal heart sound, use of diaphragm, the larger part of the stethoscope. For high pitch sounds like all other sounds, rest all sounds. S1. Normally M1 precedes T1. It is loud, S1 is loud in case of MS, TS, hyperdynamic states, tachycardia, short PR interval. It is S1 is soft in case of MR, tricuspid regurgitation, MS, MR, MI, left ventricular failure, bradycardia, prolonged PR interval, calcification, poor conduction due to thick chest, lung, pericardium. Variable atrial fibrillation, complete heart block. Wide split is seen in RBB, right bundle branch block. LV pacing, Epstein's anomaly. Reverse split is seen in LBB, left bundle branch block. RV pacing, severe MS. And yeah, that's it. S2, normally A2 is followed by P2, A2, P2. Normal split in expiration is not heard because it is less than 20 milliseconds. Normal split in inspiration can be heard because it is more than 20 milliseconds. So this is how, okay, so they have differentiated between A2 and P2. They explained what is A2 and what's P2. So A2 is loud in hypertension, hyperdynamic states, ascending aorta aneurysm. P2 is loud in pulmonary hypertension, pulmonary artery dilation. A2 is soft in AS, AR, poor conduction due to thick chest, pleura, lung. P2 is soft in PS, PR, poor conduction due to thick chest, pleura, lung. A2, there's a wide split with early A2 in MS, MR, and VST. And P2 wide split is because of delayed P2 in pulmonary hypertension, PS, RBB, B, LV pacing, and LV ectopic. Narrow or reverse split of single S2 with late A2. It's seen in AS, hypertension, HOCM, coarctation of aorta, LVBB, RV ectopic, RV pacing, PDA. And narrow or reverse split or single S2 because of an early P2, it will be seen in case of TS or Eisenmengerization, Eisenmenger phenomenon. Okay. I think let's stop here.